Okay, our next presentation, I want to tell you a little bit how we got here, and then I'm going to introduce our speakers. So thank you all for being with us this morning. A number of months back, we heard about a program and what's going on at UAB, and we wanted to learn more about that, and we called and had the opportunity to have a conference call with the two physicians that I'll be introducing here in just a moment, along with a few other folks that are a part of their team. And as we learned about the program, we thought that this would be something that would be good for our quality forum. We actually had a presentation at our quality task force, and many of you in the room may have been there for that presentation. And again, we found it to be a very worthy presentation, and one that I think the principles of which we can actually institute in a lot of different ways in our organization. You're going to hear them talk about their story and what they're doing. But let me invite you, as you listen to this, to take the principles and the concepts and say, is there the opportunity to spread this into other areas of your institution, irregardless of size, irregardless of the program of work. You'll hear them being fairly prescriptive about the work that they're doing at UAB on it. But as I listened to it, it certainly was one of those moments that made me scratch my head and say, I wonder what the underlying principles would do if we considered this in a variety of areas. So with that background, or as thought, let me introduce our next speakers. They come to us from UAB, as I described just a few minutes ago. It's called the Enhanced Recovery After Surgery Program. And again, we're blessed today to have two great presenters from UAB. They've been extensively involved in the development of the program. First is Dr. Melanie Morris. She's an associate professor in the Division of Gastrointestinal Surgery at UAB. She serves as the chief of general surgery and chief of colorectal surgery at the VA Medical Center, also here in Birmingham. In addition to her medical degree, Dr. Morris also has a graduate certificate in healthcare quality and safety from UAB. To her right is Dr. Daniel I, who is an assistant professor in the Division of Gastroenterology Surgery at UAB. Now, his education, he and I were classmates. As I read all of this, I want y'all to be very impressed I'm kidding. He completed his undergraduate at Yale Medical School at the Johns Hopkins School of Medicine, and after residency at Boston University Medical Center, he completed a colon and rectal surgery fellowship at the Mayo Clinic. So he has a few credentials here to go along with this presentation today. Dr. Morris and Dr. Chu will tell us all about the enhanced recovery after surgery, and we'll also try to have a few minutes at the end for questions. So, Dr. Morris, Dr. Chu. Thank you.
Great. Thank you for this opportunity and to the Alabama Hospital Association for this chance to share some of our work on enhanced recovery. No disclosures. So if we think about surgery and what it means now to recover from major surgery, we've come really far. So you look at this picture, this is kind of the history of surgery. Surgeons were barbers, patients were on the table, fully awake, and a good surgeon was one that could perform the surgery as quick as possible because there's no anesthesia. This really has evolved, really only recently, in the last couple centuries. 1735 was the first successful appendectomy. This patient did not die after surgery. This was considered successful. And you can see the patient's completely wide awake there. Fast forward another 100 years to the mid-19th century, and we go to MGH, where there's the famous ether dome. This is the first time that someone thought that maybe we can put the patient to sleep with some ether. And there's Dr. Morton there, and then there's Dr. Warren, who was the first dean of the medical school at Harvard, performing a resection of a neck vascular tumor. And you can see the procedure being done here. The patient is actually asleep and did not remember anything in this procedure. Go back forward another 50 years, 1904, and you go to Johns Hopkins, and this is William Halsted, who's really considered the forefather of modern surgery. And you can see some semblances of modern-day surgery. They actually have gloves, latex gloves. The patient's actually asleep, and you have a lot of people standing around without masks, but they're gowned. And they're performing the surgery here, as you see. Now, everyone in this room has probably been in the operating room, and we can see now modern-day surgery is very slick. It's very clean. There's about 100 different protocols and procedures to follow now, and we even have fancy toys like robots now in these rooms. So when we think about surgical recovery, a lot of things come into mind, and if I were to poll students, staff, residents, providers, even administration, a lot of words come into mind in terms of what does it mean to recover a patient after major surgery. And if you think about it, it's very complicated. It's not as simple as just going into the operating room and coming out and you're done. There's preoperative things, there's operative things, and then there's postoperative things that you have to worry about. And recovery really has come far. If we think about the early 20th century, this is William Mayo. He used to say this: he'd rather have a resident with a nasogastric tube in his pocket than a stethoscope. And why is this? After major surgery, patients woke up after surgery with tubes everywhere, in their noses, in their bodies. And the idea was really just some dogma. The idea was that, well, if we stick a tube in someone's nose, maybe we can suck down their belly. It would prevent post-op nausea, vomiting, dehiscence, incisional hernias, and even anastomotic leakage. But this is all proven to be false. So it continues to evolve. The 1990s, a professor named Josef Fischer, who is pretty well known in surgery, published this seminal paper in one of the biggest journals in surgery, where he decided to do something crazy. He said, well, what if we actually remove the NG tube when there are actually bowel sounds? What if we don't leave it there for 7 days? What if we actually, rather than leave the patient in the bed for 7 days, we actually walk them on post-op day 2? What if we actually kept them NPO only for 2 days instead of a week? And then what if we do bowel preps and antibiotics and VTE prophylaxis? So we kind of laugh about the first 3 things that are here, but then you look at the 4th thing, this is something that even back in the 90s they were starting to think about doing that really is standard of care now. So you have to leave it to the Europeans. So Professor Kalet, who's a colorectal surgeon in Denmark, sat down and said, wait a second, well, surgery is very complicated. We're already doing all these individual things across the world to benefit patients, but no one's really thought about putting it all together. So what if we look at, well, pre-op information and teaching? What if we consistently deliver this to a patient undergoing surgery? What if we attenuate stress, provide good pain relief, exercise patients immediately after surgery? What if we do all of these things at once? So this is in 97, and in 2005 is really when this is the seminal paper for enhanced recovery after surgery, the very first paper, published in the Journal of Clinical Nutrition, which many of you read, I'm sure, and it talks about ERAS. And this is the diagram that really shows you what it is. And what is it? Well, it's 18 to 20 different processes that have been shown individually to benefit patients, but it unites it all under one umbrella and delivers it consistently to the patients. And this is really what it is nowadays. So surgery is 3 phases: pre-op, intra-op, post-op. And you can see the individual components of these specific, and I'll put these in quotations, orders that can be placed. So in the preoperative phase, if you look at this, it talks about things such as pre-admission counseling and fluid and carbohydrate loading. We don't keep patients NPO after midnight anymore. They're only NPO until 2 hours before incision time. So our patients are drinking a bottle of Gatorade up until they park in the parking lot at UAB. And this is the idea behind this is that we've realized people become really dehydrated through surgeries. If you look at the intraoperative phase, we work on things like short-acting anesthetics, and we work on neuroaxial blocks. So all of our patients at UAB, the morning of surgery, they'll be asked to receive a spinal anesthetic, an intrathecal single-shot injection right in the lumbar area of either a Duromorph or a dilaudid type of mix to help with pain control after surgery. And then all of our patients also get gabapentin, Tylenol, and Celebrex the morning of surgery before they go back to the operating room. And we talked a little bit about that in the last lecture. And people have shown that when you take these medicines before surgery, due to surgery, patients wake up with like a lot less pain. It's really miraculous almost. And then in the post-op phase, you can see here too, we work on a couple things. No NG tubes. We feed patients the night of surgery. Patients are expected to walk the night of surgery. And patients are not on a PCA. Okay? For us, a PCA is actually a radar alert that something is off. Patients are just on Tylenol and NSAIDs immediately after surgery. And we're talking after major colorectal abdominal operations. So this is really what ERAS breaks it down to, these 18 to 20 different components. So developed in Europe initially in the 1990s and 2000s, and it's multimodal. We used that term before in the last lecture. Okay? This is really what it means by multimodal strategies. And it minimizes the stress and dysfunction after surgery, and in numerous studies in the last 10 years have shown it consistently. It reduces length of stay after surgery, it can reduce post-op complications, cost, not surprisingly, with no increase in readmissions or mortality. Because some people will say, well, you discharge patients 3 days earlier, will they be readmitted? And the answer actually is no, because patients are just doing better. Now, what's interesting is that this started in Europe, and really in the last 7 years here in the United States, it's been slowly being adopted, and I'm going to show some data on this. But there's certainly a snowball effect, and we're going to hear this more and more now. The lay press has also gotten wind of this. So 2015, Wall Street Journal featured a big article on enhanced recovery after surgery. And then in 2017, just this year, a major review publication, which if you have my slides, the link is down in the lower left, you can click on, really summarizes everything about ERAS. And if you read that paper, you'll get it. And it talks about all the details about it. Now, from a research standpoint, ERAS is here to stay. If you look over the years in terms of the publications and research that's done on this protocol, it's just continuing to increase exponentially. So whether you like it or not, you're going to hear more and more about it. So this is a breakdown of what's been happening across the country. If you look at the major institutions, Mayo Clinic was one of the first early adopters of ERAS in 2009 with their publications in 2012. And you can see Oregon Health, Duke University, UVA, all published their results on ERAS. And if I had to walk you through this table, if you look at the reference length of stay, this is where the hospitals were at before implementing ERAS, which is very typical. Colorectal patients are sort of the worst of the worst. We deal with stool. When we operate on them, they have ileuses, they have the longest length of stays, the most complications, so really high-risk population and good population to do quality improvement projects like this. So typically it's 7 days for length of stays. And you can see they're reduced by about 2 days or so with the implementation of ERAS. Mayo's a little unusual because Mayo already had, as you can see, a fast-track plan enacted early on. But they were able to show that they reduced their interquartile range from 3 to 5 to 2 to 3, even with ERAS. And they're discharging patients on post-op day 2 after major surgeries up there. The morbidities can be improved with ERAS depending on where you start. And then readmission rates can also improve, again, depending on where you start. So if you're already good at it, the effects might be more incremental. But most importantly, and this is something that people are looking more into, is the cost savings, as you can expect with having improved outcomes in surgery. And so this is the general theme that you're going to see with ERAS: length of stay, readmissions, morbidities, and cost. So in summary, ERAS links pre-operative and post-operative processes. It's collaborative, it's multidisciplinary. Most importantly, it's simple. Okay, it's nothing fancy. We're already doing this at every hospital, but what it does is it just links it all together in a very organized and structured manner. So this is not a $2 million robot. These are just simple orders that can be placed. And most importantly, I hope I've shown you through some of the data that it absolutely works, and every institution is showing this consistently. So for the rest of the talk, just go through 5 quick questions. Does ERAS work in other specialties? How do you implement it? What components might make it work, you might wonder? Why is it important? And then some of the outcomes that we've had at UAB. So one slide, does it work in other specialties? The answer is yes. ERAS is spreading to other specialties. This is a summary table that shows you in 2012, that was when the first international guidelines on ERAS came about. And you can see it's for colon surgery and rectal surgeries, because again, these are kind of the worst outcomes. But then you can see it's expanding. You have Whipples. That's the duodenectomies, the third one there. The people are doing ERAS for Whipples, because patients who undergo Whipple procedures also have incredibly long length of stays and complications and readmissions. So another population that's very targetable with QI efforts. Cystectomies, for those who work in urology, also major surgery. And you can see how it's evolved since 2012, even till this very year, where under production you have these other protocols for hip and knee replacements. And so while I talk about these 4 benefits, length of stay, readmissions, morbidities, and cost, we're also starting to see some other value in ERAS, such as these hip and knee replacements, where the length of stays aren't necessarily very long, like 7 days, but there are benefits to patient satisfaction, to pain management, to non-opioid pain management. So we're going to start seeing ERAS applied in multiple surgical specialties. And Melanie's going to talk a little bit more about this, but at the federal level, ERAS has really gained the attention of the AHRQ, as many of us are familiar with, and they've actually just as of this year began implementing a project to spread ERAS across 700 plus hospitals across the United States, focusing in cohort 1 initially on colorectal, and then slow expansion, as you see, through the other specialties. Okay, well, how do you implement ERAS? And this is some of the principles that I hope to take away, maybe not specifically how we did this. Many of the folks in the room here know about implementation science. This is a study of how you uptake research findings in evidence-based practice, or as I call it, the science of learning how to just do it. Now, implementing ERAS is changing culture, and this is always an interesting topic because in my mind, culture is really a product of your habits and then expectations within an institution. So when you implement ERAS, at least in my mind, it's really an issue of changing some of the habits and then changing some of the expectations for both patients, providers, and even the healthcare system. So how do we used to do this? Well, surgery used to have great ideas, and then when it didn't when it never got implemented, we would blame anesthesia. So this is not the right way to do things nowadays. The framework has become much more serious, right? With knowledge to action cycles, with the plan, do, check, act cycle. Some of you guys might know this, but these are frameworks that are out there. And so we use the PDCA cycle at UAB to help us figure out how to implement ERAS. And a couple things. Number one, you had to identify key champions. And if I had to end the slide here, this would be the most important part. And I think all of us intuitively know this, all of us have experienced this. You have to have the right people, the people with the passion on that team, a core team, just a few people. But if you can get those people there, things tend to snowball, things tend to start changing. So we identified the key champions, we assembled a task force, we constructed a protocol that's tailored to UAB, we pilot studied it, educated, troubleshot, and then implemented widespread adoption. So there's a planning phase, there's a do phase, a checking, acting, and then it cycles again. And so we all know QI is continuous. So it all started in 2014, right after I finished my fellowship with an APR for low rectal cancer, OR 702. I was the rookie. I asked anesthesia, can we do a spinal? Because this is how we did it at the Mayo Clinic. Anesthesia was also a rookie, also came from outside UAB. And he said, sure. So we did it, and then we got in a lot of trouble because this is against protocol. So we learned our lesson there, but this is our core group. Okay, we have anesthesia, we have surgery, and we have nursing. And I cannot emphasize enough how important nursing was to the success of this program. I didn't know Darren Brown was going to be here. He's sitting right over there, so I'm going to embarrass him a little bit here. But Darren Brown was absolutely the key to the successful rollout and education of the entire nursing staff, because nurses are really the common factor from the preoperative to the postoperative phases and are really critical to programs such as this. And so Darren really was a fulcrum in terms of how this worked at UAB. So we assembled a task force, and then this, as you can imagine, quickly expanded, right? But we still have our core group. Hidden on all these names is just those 4 people. But this expanded quickly to other specialties, and we talked a little bit last lecture about multidisciplinary teams, and as you can see, this is a multidisciplinary team. We have not only pharmacists and informatics, but we even have the residents involved, the trainees, right? Because these guys are in the trenches, and so they're the ones that really see what's going on day to day. And after constructing the protocol, I won't bore you with this, but this is all available. This is public information on any of those websites. We piloted in about 5 patients, got good results, expanded out to 35 patients, also had pretty good results with the length of stay that was reduced from 7 days to about 4 days. And then we began educating and troubleshooting, because inevitably, when you change something in an institution, you're going to come across barriers. So people have studied this. Toronto really studied this. They implemented ERAS in 20 hospitals across the province of around Toronto and ran into all kinds of problems, you can imagine. And there are a couple here. Nurses. You had to have nurses on board. Variability. Surgeons often aren't all in line with each other, right? The greatest understatement of all times. Resistance to change. What do you have your person there? I just don't like changing anything. What do you do about that? That may be one of the hardest ones to deal with. And then buy-in. You have to have your institution believe in this program too. So really, the barriers happen at the individual level and also at the institutional level. And I would say at UAB, our experience is that we went through all of this with, and we're able to surmount this. And of course, we got UAB Care involved, which is Dr. Rue's program. And they're the institutional buy-in that really helped formalize this. So what components make it work? I'll just go quickly through this. But multiple people have looked at these individual components. And I'll say right now that some of the key components are highlighted here. Patient education, extremely important. ERAS really forces you to talk to the patient and explain everything. And I don't think we were doing this very well before. And then multimodal analgesics. I'll talk a little bit about this. Non-opioid medications. And then some of the other techniques as you see here. And people have studied this, looking in large groups in Europe in terms of what factors actually matter. And people have found that certain factors, like loading patients with carbohydrate drinks before surgery, makes a difference in length of stay. And in reducing complications, minimizing the amount of fluids. Don't flood the patients with 10 liters of fluid during the operation. We know that that does not benefit patients. And then randomized trials have also shown that early feeding and early mobilization benefit patients, and they do very well with this. And then the bottom line also is that with increased ERAS compliance, the more of those 20 metrics you can follow, the better the effect of ERAS, with reductions in length of stay and the other metrics that we talked about. So I'll just have Melanie finish off here.
Thanks, Dan. So why is enhanced recovery important? So we've already shown you some of these things, right? It decreases length of stay, it decreases postoperative complications, and it decreases readmissions. But really, it can't just be about length of stay. And really, what we care about here, what all of us in the room care about, is providing high-value care, both for our patients and for the providers and for our health systems. And really, we need to be addressing quality, safety, patient satisfaction, and cost. And I'm going to make an argument to you that enhanced recovery does all these things. But so what do patients really care about? Are their goals in line with ours? So this is a great study, and I'm not going to go through all the details in the interest of time, but it basically it had patients rank what outcomes were most important to them following colorectal surgery under an enhanced recovery pathway. And what patients care about the most is freedom from nausea and freedom from pain at rest. And the way they thought that this could be mitigated best is with preoperative counseling and avoiding infections. So what about providers? The study also looks at what providers thought that patients cared about, and providers correctly identified that patients cared about freedom from nausea and freedom from pain at rest. They also recognized that preoperative counseling, early mobilization, and optimization of IV fluids were good strategies. And both patients and providers realized that early discharge and early return of bowel function, patients don't really care about that. So I would argue that enhanced recovery, part of in that intraoperative phase and postoperative phase, is addressing pain control and aggressive management of nausea and vomiting control. So this sort of highlights that we're addressing what patients care about as well. So an interesting thing that we have noticed, and I'll show you more when I go over our UAB data, is that we actually had some racial disparities in our colorectal surgery patients at UAB, and enhanced recovery, by standardizing the care that we're delivering to every patient every time, is reducing these disparities. And this is a big priority with the National Institutes of Health right now, making sure that we are providing the best care to every patient every time, and I'll tell you a little bit more about that. So enhanced recovery, really, ERAS is the great platform to really provide the access and delivery of best evidence-based care to surgical patients every time. So I'm going to go over some of our outcomes at UAB, and I don't want you to get bogged down in some of the details, so some of the slides I'll just point out the important parts. So when we most recently looked at this, we've had over 1,000 patients who've been treated on an enhanced recovery pathway. Our median length of stay is 3 days, and our mean length of stay is 5 days. We do still have some high outliers, as you can see on the graph, but the majority of patients are going home within 4 days of surgery. So this is talking about the racial disparities that I briefly mentioned. So we looked at our patients before we implemented enhanced recovery and after. So our African American patients are the blue bars, and our white patients are the red bars. We calculated what their expected length of stay would be based on the NSQIP risk calculator, and we found that all the patients should have been in the hospital about 6 days. Well, how long were our patients staying? So before enhanced recovery, our African American patients were actually staying 10 days, and our Caucasian patients were staying 7 days. And then if you look at the furthest set of bars on your right, that's after implementing enhanced recovery. And not only did we decrease length of stay for everyone, but we eliminated that disparity between our races. And this slide even highlights it even further. So our African American patients were staying almost 3 days longer than was expected. And after enhanced recovery, everyone's going home sooner than expected, but we really showed the most benefit in our African American patients, who now go home sooner than our Caucasian patients. A couple of these slides are just to show what our volume was as we were implementing this, just so you get an idea. And as you see, we sort of were able to continue providing enhanced recovery care to a significant number of patients and had very few people off of the enhanced recovery pathway. This shows just a timeline of our implementing and then sustainment, that we were able to achieve this sustainment over time. And this slide, so if you look at the green line, so that would be the expected length of stay. The blue line represents patients who were not on an enhanced recovery pathway during that time, and the red line shows the patients who were on the enhanced recovery. So as you can see, the patients on enhanced recovery were going home sooner than expected, and those that were not on the pathway had longer lengths of stay. So are we really decreasing cost at UAB by doing enhanced recovery? I mean, isn't this all really expensive to implement? It sounds complicated and expensive. So the blue line shows our patients who were not treated on an enhanced recovery pathway, and the red bar shows patients who were treated on the enhanced recovery pathway. So this shows the average variable cost per case. So we were having a cost savings by putting patients on enhanced recovery pathways. So, well, maybe it's more expensive from the pharmacy perspective, since we're now using multimodal pain anesthesia. I mean, those spinals must be expensive. No, so if you look at our data, so the blue line again shows patients who were not treated on an enhanced recovery pathway, and the orange line shows patients that were. So you can see our enhanced recovery patients had decreased overall pharmacy costs as well. So what about complications? Are we hurting patients by doing enhanced recovery? The answer is no. So if you look at the blue bars, those are patients who were treated before enhanced recovery, and the red bars are patients who were treated on our enhanced recovery pathway. And you'll see there's really no difference overall in complications, including surgical site infections, urinary tract infections, and sepsis. Again, this surgical site infection, it really depends on where your bar is when you're starting. At the Duke experience, they had about a 30% surgical site infection rate. They then implemented enhanced recovery, and they saw some improvement in their surgical site infection rate, but then they had to do a further dive, and they implemented a specific SSI reduction bundle, and then got the desired results over time. But the enhanced recovery pathway is a good starting point and can be used as a tool to decrease your SSI rates if that's a problem in your institution. So are we having more patients readmitted? We saw nationally that people don't. Well, no. So if you look at the first set of bar graphs on the left, the blue bars again are patients who were readmitted before enhanced recovery, and the red are patients after enhanced recovery. And our readmission rates are about 15 or 16% in each group, so not significantly different. The only difference that we have seen, and we're working on this right now, is we have seen a little bit of an increase in acute kidney injury in our patients who are treated on the enhanced recovery pathway. I don't want this to scare you away. None of these patients have gone on to need dialysis or have had any long-lasting effects. So that is part of our PDSA cycle, where we are chart reviewing all these patients to understand where we have opportunities for improvement now. Certainly we do things on the enhanced recovery pathway, such as limit IV fluids intraoperatively. We give them Toradol and other NSAIDs. We may be stacking a couple of things. So like I said, more to come, and we're going to fix that problem. So, to highlight what we just heard in the last talk, another benefit of the enhanced recovery pathway is we are decreasing the amount of opioids that our patients are getting. And I just want to tell you one quick story that I think highlights this so well. I took care of a young woman who was 19 years old who was in a horrible traumatic accident that resulted in a colostomy. I'm a colorectal surgeon, so she got sent to me to talk about closing her colostomy. Well, during her first hospital stay, which was a significant period of time on the trauma service, she had a ton of opioids prescribed to her. She went home with a large opioid prescription, and she got addicted and had to go through a drug treatment program. This was a healthy 19-year-old woman. When she came in to talk about having her colostomy reversed, she and her mother were both appropriately very concerned. We treated her on our enhanced recovery pathway. She got the spinal pre-op. She took no narcotics post-operatively, and she went home with no narcotics. And her pain control was excellent, and she was super pleased with her care overall. So these I just want to briefly go over these. So the blue bars are on the bar chart are patients who underwent the enhanced recovery pathway. The red is patients who were before the enhanced recovery pathway. And so if you look at discharge, there's a significant decrease. These are oral morphine equivalents. There's a significant decrease in the oral morphine equivalents, both at discharge and overall. When you look at the pie charts, the blue are oxycodone or hydrocodone prescriptions. The green is tramadol. The red is tramadol plus oxycodone or hydrocodone, and the orange is none. So when you look at pre-enhanced recovery at discharge, we were giving patients a lot of narcotics. When you looked at pre-enhanced recovery, well, when you compare that to enhanced recovery at discharge, you can see much fewer amounts of opioids are prescribed. And then when you look at within 1 year, both before enhanced recovery, again, we were giving a large amount of narcotics, and now we're not giving as many at all to our patients. And we're continuing to work on this. So in summary, enhanced recovery does work across surgical disciplines. Expect more to come, as Dan said. It requires a framework, but it's doable. We don't want this to scare you away. It doesn't have to be this complicated or formalized, and it will require tailoring to any institution. And we do know that increasing enhanced recovery compliance overall increases the effectiveness. We don't totally understand the specific mechanisms, but it really doesn't matter as long as you're getting better outcomes. We think that enhanced recovery is valuable and that it really benefits patients, providers, and the health system overall. And there may be additional value, and we think there certainly is, other than just length of stay. So I wanted to spend just a moment on this. So as Dan mentioned, the Agency for Healthcare Quality and Research, the AHRQ, has partnered with the American College of Surgeons. They believe that enhanced recovery is very important, and they're spending a significant amount of time, money, and energy and effort to get the word out and to help hospitals implement this. So you can see that they say that enhanced recovery will improve the uptake of multimodal analgesia and decrease opioid use, reduce SSIs, reduce CAUTIs, reduce VTEs, improvement in the patient experience, improve your culture of safety, improve lengths of stay and readmissions. And what are the benefits to hospitals that want to participate in this? You'll have access to U.S. leaders in perioperative quality. They will give you the order sets if you're on Cerner or Epic. If you're not, you can tailor it to your electronic medical record. They'll give you patient education materials, all the things that you need to implement it. Monthly coaching calls, in-person training sessions, a nurse consultant, and then some access to some data collection platforms. I've put Stacy McSwine's contact information at the bottom. The whole handout about this should be available on the website. I've had the privilege to serve as one of the technical experts for a panel that has put this together, and there are a lot of wonderful resources available to really make this easy for you. And we really think that enhanced recovery is the perfect thing to put together a great quality improvement team with a surgeon champion, an anesthesia champion, nursing, to get everybody at the table. That's an easy win. We know this works. We know you can do it. As was mentioned earlier, I'm the chief of surgery at the VA. We have implemented this at the Birmingham VA. If we can implement it at the VA, you can implement it in your hospital. So with that, Dan and I really just want to thank you for the privilege of being here today, and we're so excited to be a resource for you guys. We really want to help improve surgical care across the whole state of Alabama. We'll be around even after the talk if you have other questions, and we're happy to answer them now and later. So thanks. Any questions? Yes.
You're liberal on the fluids pre-op, but you were restricting fluids intraoperatively. What was the theory behind restricting the fluids intraoperatively?
Yeah, so I would say, we say restricted fluid, but really we're trying to maintain euvolemia for the patients. And so it's not that we're withholding fluids, but we are keeping it at what the anesthesiologist can assess as to what they think is euvolemia. And so, example, laparoscopic cases with the amount of loss, insensible losses that one would expect, we typically average about 400, 500 cc's an hour for a laparoscopic case. So a 2-hour laparoscopic right colectomy, the patient will come out with about 800 cc's or 1,000 cc's of IV fluids instead of 2 liters as previously given. And people have shown this not only in colorectal, but also even in some of the other specialties, that this euvolemia it really benefits patients. Because we think hypervolemia causes ileus also, is what people have also shown. Mm-hmm.
Yes.
So are you doing this only on the minimally invasive procedures or the open procedures as well?
Yeah, so we're doing it on everybody and anything. So open, laparoscopic, robotic. And I would say, so that's for colorectal. Now what's interesting is since we've done this for colorectal in the last year, with the help of UAB Care, we've been implementing this across urology. So our urologists who are performing the cystectomies are also doing this. And GYN oncology at UAB has also begun implementing ERAS with great results for their big operations. And GYN benign is starting to implement it for hysterectomies. to benefit patients. And not really so much for the length of stay benefit, but for the patient satisfaction, for the pain control, avoiding narcotics. Those are the things that they're getting benefits from. And we'll be doing this too for vascular surgery. So our vascular surgeons are actually coming online and are chomping at the bit to do this for their lower extremity bypass patients, because those patients stay in the hospital for 7 days also.
And I just wanted to say too, on the AHRQ slide from earlier, the first cohort that they're doing is colorectal surgery, but the next one is orthopedic surgery. So even if your hospital doesn't do a lot of colectomies, they'll be recruiting hospitals and systems soon to participate for orthopedics. And their other future targeted areas are bariatrics and acute care surgery. So if you think, well, my hospital doesn't do Whipples or colectomies, that doesn't mean you can't still do an enhanced recovery pathway that would benefit your patients.
What kinds of changes are you making to address the acute kidney injury?
Yeah, so this probably happened in the last couple months when we've been looking at this data. And one of the things that we found was we were stacking the NSAIDs. So meaning anesthesia was giving a dose of Toradol, 15 milligrams, before waking up the patient. And then what was happening was that immediately after surgery, the patients were getting Toradol within 6 hours of that previous dose. So there was some stacking that was going on with the NSAIDs. These patients with ERAS, because we keep patients euvolemic and they're not overloaded with fluids coming on board, they're sort of teetering a little bit already. With colorectal, we also bowel prep patients, so they're also a little bit kind of right in the kind of a very sensitive spot. And if we hit them with too many things like these NSAIDs, we think that's what's happening. We're tipping the patients over into this temporary acute renal injury. So we're unstacking the NSAIDs right now is one immediate thing that we're doing. And we're also kind of paying more attention to the amount of fluids too that anesthesia is giving intraoperatively. Because it could be that we've kind of gone a little overboard with anesthesia in terms of being restricted with the fluids, and that we're giving actually too less fluids right now.
And I'll say, I think 2 points. One, that's important why you collect the data, right? Like that's why you do the PDSA cycles. You implement something and then you've got to make sure you're doing the right thing and is there anything I need to change? So if you choose to participate in the AHRQ program, you will be required to do data collection. It won't be onerous and they will help you do that. So you can sort of fine tune these things. The other thing we did is resident education. So I feel like our residents thought they're on the pathway, they have to stay on the pathway. These are just a set of guidelines. So really you want to treat the patient. And so we usually turn off the IV fluids after post-op day 1, but some patients need more IV fluids. And so I think with a little re-education of the residents as well, and we've already seen an improvement in our acute kidney injuries already going down.
Great, thank you. You can Twitter us or email us. We'll get with everything.
Dr. Hsu, Dr. Morris, thank y'all very much. I think you could tell by the questions that you certainly stimulated the thinking, and I certainly commend to all of you that this clearly is a classic demonstration of innovative thinking and innovative actions as it relates to perhaps looking at the status quo of how we do things. And I hope you can kind of connect the dots, and I'm sure you have, that this has implications in a variety of ways for us. It could be that it impacts length of stay. It could be that it impacts the opioid usage and the medications and ambulation, early ambulation, which was a part of our early conversations at last Quality Forum. Again, I think it's a good opportunity for all of us to kind of think about the things we do and evaluate ways in which we can expand.